Hello, hello, hello. This is Truth Be Told. This is Dr. Walter Aka.
I
I
no,
think you have.
I'm the guest here today. I
He
thought
is a guest.
Horton was
Horton.
next.
Well, I'm Dr. Leroy Horton.
And we all know Dr. Kyle Dumpert. He is actually rotated now as the guest for today.
That's right.
But so I'm excited. I'm excited because he's coming on to talk about, a life, the life as a rural dentist. He lives in Bedford, Pennsylvania, very small town, 2 hours outside of Pittsburgh, 3 hours outside of Philly, about 2 hours outside of Erie, Pennsylvania.
3 hours outside of
3 hours,
here,
and then 3 hours outside of West Virginia. So as you can see, he's pretty centralized, but not really, right?
yeah,
From
yeah.
any major city.
2 to
So
3 hours. Pittsburgh, Philly, DC, Baltimore can get to all of them.
That's it, but it takes like 3 hours, right?
Yep.
Yeah, and so that's it. So you're close enough, but far enough, right? And so
Yep.
I wanted to ask you, the first question that I have for you is, in your town, how many dentists are there?
But before you get to that, I've been inspired since Leroy stopped or kind of up the game. So let me do this.
Hey, let's go.
We've
So
lost
if you
all
want to find my
we've lost all-
information, right there, click the QR code.
We've lost all credibility. Thank you.
Listen, greatness inspires greatness. What can I say?
That's
right,
what
that's
what you want to call it. We'll pretend that that's the truth. But okay, so now that everybody can, scan your QR code, let's talk about how many dentists are in Bedford, Pennsylvania.
Right now, there are currently 6 dentists in Bedford County.
6 dentists.
Oh, the whole county.
In the whole, yeah, right, in the whole area, right? And
Wow.
and how many specialists? Like, let's just say, how many orthodontists?
1
How many periodontists?
in the county. 0.
How many prosthodontists?
0
Endodontists?
in the county. 0.
Right. And so, just with that being said, how many of these procedures do you have to do yourself?
Pretty much all of them. Orthodontist, I can get to. He's right in town, but endodontist is about a 30-day wait to get in to see him. Oral surgery is probably 6-month wait to get in to see. Periodontist, closest one, is about 45 minutes. I'm kind of right in between 2 of them. So I think they're probably 2 to 3 months to get in to see a periodontist.
So what I'm hearing, Kyle, is that 4 out of 5 dentists do not want to live in Bedford. Why are you there? And I think that's an honest question. Like, what's the appeal for someone who can essentially make a living anywhere to be in a rural town?
So what brought me here is I was born and raised here. So it's easy to come back to your hometown. There's some benefits and challenges that come along with that. Benefit is everybody knows you. Go to the grocery store, go to Walmart. You know a lot of people there. Bad thing is, if you don't like that community, or seeing your patients out in public, or working on your 3rd grade teacher or your high school teachers or any of your classmates going through school that are still in town, that is something that you have to deal with. So there is a history there also that, if you weren't that great a person growing up in town, then you're probably not going to have that great of a practice. People can reimagine themselves, and we all have gone through some growing pains, but that can be a challenge, especially if people think there's a prior relationship there and they don't look at you as a professional. They look at you as, hey, we went to school together. Can you cut me a deal on this? I shouldn't have to pay the bill. You're not going to send me to collections, are you? And yeah, I am. That's the agreement we had set up. So there are some challenges along with that. But to answer your question, aside from growing up here, there's a lot of business benefits. As far as my marketing expense is 0. So I don't spend any money on marketing. Other benefits are competition is really minimal. I don't even look at it as competition. It's a dental community here. There's enough patients for everybody to go around. There's no need to kind of fight for patients. There's a couple people that advertise on billboards and stuff, but most of it is word of mouth or Google advertising. So that is a benefit, as well as you can pretty much practice however you want, and the type of procedure you want to do, there's a demand for it. So if you're willing to put in the continuing education and get up to that level, you're able to see that type of practice.
Okay.
So everybody says, if you want to make money, you should go live in a rural area. If you're a dentist and you want to make money, why? Because if you're in the city, in one building, you might have 6 dentists in one building. Or, if you're looking around and you're in the street, if you're in an intersection of a street, you may see a dentist across the way from you on the other side. So you have a lot of congestion for dentists. So basically the patients to dentist ratio is skewed, right? It's very small, right? So would you agree that if you want to make good money, definitely you need to go into the rural area? And then can you tell me what's kind of like the caveat to that? What's the opposite of that? What's basically, what part would you disagree with in that statement?
Oh, we lost him. Well, let's see if that connection comes back.
There
My
it
bad.
is.
Sorry about that. Google has a VPN that likes to connect and keep me safe. The question was, repeat that.
The question was, whenever you hear anybody talking, right? You hear, hey, if you want to make good money, you need to go to the rural areas, right?
Right.
And that's something that we've been taught for a very long time. But the problem is, if you are in the city, you'll have a lot of dentists. You could be in a building and have 6 dentists in that building. Right. And if you're in the rural, do you believe that you would actually make good money? And then what would be something that people don't, if you had to finish that sentence, what would be something that people don't tell you about living in the rural area and making that money?
So, yes, I think there is a greater potential to make money. If you're looking at the overall business expense, you have the opportunity to own your own building, your own real estate. So you can be in control of your destiny more if you own your own property. You can make the changes you want. You're not stuck in a triple net lease where other people are benefiting. So that's, you here have multiple sources of income. Owning the real estate is a source of income that you're not paying to somebody else. You're generating money from that asset that you can later capitalize on. So outside of dentistry, that's one way you can make more money. Second way is competition is pretty minimal. Like I said, there's 6 practicing dentists within the whole county. County population is about 55,000. The downside of that is being rural. There is a high Medicaid population. So it depends on the kind of practice you want to set up. I bought a practice that had a lot of Medicaid patients, and I've transformed it to a PPO practice. And now I'm transitioning that to more of a fee-for-service practice. So as people get to know you, get to know your skills, happy with the practice, happy with how they're treated and the results of the work, you can slowly start to cut out those insurances. And because patients don't have many other offices or options to go to, you can it's a little bit easier, in my opinion, based on my experience, that you can change that perception of relying on insurance to dental insurance can help pay for your benefits, but it's not the end all be all as far as payment goes.
Oh, let me ask you, because I think you bring up a good point of phasing out low reimbursing insurances, especially state insurance. Let's say I'm the layperson and we're playing devil's advocate, and I say, well, it sounds to me like you just want to make more money. right? Can you school me as to the dollars in, dollars out as to why someone would make the decision of phasing out the low reimbursing insurances versus maintaining them as a large part of their practice?
So I'll talk on Medicaid first because that was the first one I phased out. I believe it was when I was in dental school. So I'm going to say around 2011, Pennsylvania Medicaid stopped covering a lot of procedures. So dentures went to once in a lifetime. They covered extractions, they covered amalgams, composite restorations, root canals, crowns, perio, those things weren't covered. So they were coming in, they could get their cleaning, their fillings, one set of dentures, and some extractions. And that really, I think, pushed people to practice in a way that wasn't ideal. Patients with that have the expectation of, I don't have to pay for anything, my insurance covers it. So when somebody has a four surface amalgam and the tooth is breaking down, best option would be a crown for that patient. That patient doesn't see the value of investing in a crown. My insurance covers a filling. Let's just do a filling there. Okay. They talk the dentist into doing a filling. The tooth continues to chip and break apart. It's now, you're putting a four surface composite in there. The tooth breaks 6 months later because ideally it needed a crown. You do another filling because you don't want to take the tooth out. It's still a savable tooth, but because of limitations with Medicaid, you don't get paid for it that second time, third time, fourth time. So you're doing lower quality, lower reimbursing work. You're redoing it multiple times because dentists, on a whole, want to help people, don't want to take something that can still be functional when the patient, when their mindset is, I shouldn't have to pay anything out of pocket, my insurance covers it. So Medicaid office, that is one of the challenges. The other challenge is typically that patient population, you have a 50% no-show rate. So again, you're not putting the money in out of your own pocket, so you don't value the care that you're receiving. So it's easy to blow off appointments that you're not financially invested in. So those types of practices have to overbook with the expectation of half of these people aren't going to show. If they are going to show, then we're going through treatment a lot faster, maybe cutting corners because they're lower reimbursing. You have to figure out different supplies that you can maybe downgrade to, so you're not losing money anytime somebody walks through the door. So you really have to look at your expenses and do that high volume of care. And maybe you're doing a filling once, and if it doesn't work, you're taking a tooth out. So you're edentulating a lot of people that otherwise wouldn't need it.
And for the layperson that may not realize it, when you say low reimbursement, let's say your fee is for something X is $500. A PPO might pay you $400. Medicaid comparatively might pay you $50.
Okay.
Right. And maybe I'm exaggerating a little bit, but I think some people don't really understand how big that differential is to where a lot of times you're losing money seeing a patient, especially in a way that is providing quality and time and all that.
So when a practice sets their fees, there is a national fee schedule that you can look up your zip code and find out what percent of your where your fees should be with in a certain percentage. So if you're at the 80th percentile of your fee range, then you're higher than 80% of, or you're at the 80th percentile of what that is. So that's the goal from my understanding. Most practice consultants want you at that 80th percentile. They don't want you at the highest rate. They don't really want you any lower than that. In my area, PPO insurances are, if I'm at that 80th percentile, so let's say a crown is $1,200, they're going to reimburse somewhere in the $700 to $800 range. Medicaid isn't going to pay for a crown. If it's let's say a 4-surface filling. If you're at the 80th percentile at $385 for a filling, PPO may reimburse you for $150 of that in my area. Medicaid would probably reimburse half of that, so about $75. So considerable write-off. So you have to have that McDonald's mindset of, I'm going to get in as many people at a low cost and really have my system set up so I can, have that dental mill of people coming in and out as fast as possible.
Right.
Let me ask you a question, Kyle. So I'm playing devil's advocate, and we always have to preface it by saying that, but really, we got to stop saying that. Everybody knows that we play devil's advocate. We all know we play devil's advocate. But so Kyle, so you stopped taking Medicaid, right?
Yep.
Where are those patients gonna go when there aren't that many other dentists that will treat them? Because if everybody does what you did, then who's gonna see those patients? And then that brings me on to the next. Yeah, that brings me on to the next issue, which is dentists seem to get mad whenever the government steps in and says we're gonna, give license to some of these advanced, practitioners.
Oral health specialists and
what is it?
The oral health specialist or
oral health specialist.
therapist,
Exactly.
Therapist.
So we basically say we don't want to see these patients, but then we get mad when somebody does it. And sees them and then says, wait a minute. Well, they're not dentists and they're not. Do you see what I'm saying? So what happens to those patients? And especially in the rural area.
Are we going down the government path already?
Well, no, I mean, I'm listening and I'm going, it's great, but hey, what's going to happen to those patients? And is this something that might just be the issue with dentists and dentistry in general, which is we want to basically keep the lights on. Right. But we're looking at it and saying, but what about those people? It's not their fault that Medicaid isn't paying. Right. It's not. It's really not their fault. So what about them? Like, what do we talk about? How do we deal with that? Especially in a rural area with 6 dentists.
Right. No, it's definitely a problem. Access to care. You hear a lot about, waiting periods to get in to see providers, access to care. Nobody takes Medicaid. In town, we do have a community health clinic. They are pretty maxed out. I've heard some patients can't get in. They're doing a limited number of procedures. So they don't have an oral surgeon. They're not doing perio. They're not doing implants. They're not doing any of those procedures. To get in to see an oral surgeon, I've heard some patients, the closest oral surgeon is like a 3.5 hour drive away. And again, you're waiting 6 months to do that. So at that point, those patients are being seen because pain is a powerful motivator to get them to come in and pay that money out of pocket to get care. But again, that option is you're losing your teeth, you're not healthy, you're not taking care of yourself. So I think the problem, and I'll try to not go too deep into a rabbit hole, but as with anything, when the government steps in and creates a welfare program and gives out handouts, it's with the best intentions because people are complaining, we can't get access to care. I'm in pain. I can't get in to see the dentist. Government's role is to try to alleviate those social burdens on the general population. But the way they go about it creates a dependency mindset where people all of a sudden, well, if I don't have to pay for it, I can drink whatever I want. I can eat whatever I want. I don't have to take care of them. I do meth, but why can't I get my teeth fixed for free? I didn't do this to myself. It was the drugs that did it to me.
Well, okay. And in all honesty, and I'm going to be fair here, in all fairness, if a patient has PPO, they still really don't care about the work that you do. Because they're like, well, my insurance paid for it. And, I feel like no matter what, patients...
It's that same mindset, because it's not coming out of the pocket.
That's it.
The PPO patients have a little bit different mindset because there are some copays involved. If it's money coming out of their paycheck where the employer doesn't cover 100% of it. But again, it's that mindset of, well, it's a benefit for my employer if they do cover 100% of my copays, if they cover my monthly premiums, and they have 100% coverage up to $1,500 a year. It's, well, I only want to do what my insurance covers because we have this mindset of insurance knows what's best for me, when we all know that isn't the case. Dental insurance is basically a coupon discount plan that gives you a limited number of benefits. So creating that, educating the patient in that regard, but addressing the Medicaid issue or the access to care issue, it's a tough one, because you want the ultimate way to eliminate that access to care issue is eliminate the disease. And to eliminate the disease, it's change your behaviors. So it's if somebody's going to pay for the treatment, there's no incentive for the patient to take care of themselves unless they're truly value having teeth in their mouth and having a healthy mouth.
Okay. Well, let's unpack that even a little further. So we brought up the notion of oral health therapists, right?
Right.
So they're a mid-level provider that could potentially, in theory, go out and serve underserved areas, right, at a more affordable cost to the state, to the insurance, to the patient, and so forth.
Right.
That reminds me of similar talk back in the day when denturists were becoming an accredited profession. Yep. It was the same exact story. It was, they're going to serve the underserved. They're going to go where dentists aren't going, because dentists don't want to go to these places. And where are denturists now? They're on every block.
Yep.
They are hiring dentists, and
yep,
they're not in the underserved areas.
Right.
Right. And I think one of the things that we are concerned about as dentists is that the state's answer, you're right, they started with a good intention of, hey, we're going to provide care for people that don't have it. They're working off a budget, and they reimburse extremely low. And I know that they know that money is an issue, because during COVID, what did Medicaid do to all their reimbursements? They skyrocketed. And I don't know if you were taking Medicaid at the time, but an extraction went from, I think it was like $59 for an extraction to $191.
Wow.
Surgical extraction, all the classifications went up, because they said, we got to get patients into the dentist and keep them out of the emergency room for extractions.
Right.
Right. And so I guess my question to you is, do you see, since we're on the issue of government, do you see the mid-level provider as a Band-Aid that we know is not going to work, as opposed to taking care of the actual problem, which is pay dentists enough to be able to see the patient and pay the bills while doing it?
So I see from what I know about dental therapists, like you said, the goal was to get them into underserved areas, but with the denturists, they too aren't going to the underserved areas. They're going to places where they can make money too, because ultimately that's, if you go into any kind of training, your ultimate goal, unless your passion is teeth and you want to work for free, your ultimate goal is to make some money while you're doing it. That's how the world goes around. For dental therapists, I see the benefit, because as long as they're well trained, I have an expanded function dental assistant that's legal in Pennsylvania. So she went to school, she got training, she can do my fillings for me. So I drill the tooth, she puts the fillings in. I hate doing fillings, so that allows me to delegate that to somebody else who can practice to the highest level of their license, and frees up time for me to practice to the highest level of my license, all while being under the same roof. The dental therapists that are able to go out on their own and maybe just be monitored remotely, I think that can be an issue, especially when they're getting into, I think they're able to do simple extractions, but we all know a simple extraction can turn surgical very easily, and something that you think can come out easy can put up a lot bigger fight than you think is going to. So I see a lot of potential there for harm to the patient. But in Pennsylvania, hygienists are allowed to administer local anesthesia. So again, that frees up time for me. If the hygienist is able to anesthetize their patients for scaling and root planing, or she doesn't have a patient in the chair, she can come to a patient that's waiting on me, numb them up for me. I can hit the ground running when I get in there. So I don't have to numb the patient. I drill the tooth and I don't have to fill the patient. So it allows me to see more patients. So if they're done in a way, or if they're utilized in a way that keeps the patient safe and still has the overview of a dentist that has had that training, has gone through dental school, can handle any of the complications that might arise, I see a huge benefit in that. Outside of that, I think practicing on your own on what amounts to a 1 or a 2 year degree, when we've all put in at least 8 years, is a little risky.
Let me ask you this, Kyle. So let me change subject real quick. Keeping up with the Joneses, right? We have that issue. A lot of dentists in the city, if you see your neighbor that just got a CBCT, for example, right? 3-dimensional image, you're like, wait a minute, now I need to get a CBCT.
Yep.
Right. But when you're in the rural areas, is that something that you guys have issues with? Like, do you have to keep up with the Joneses? And the reason why I ask that is because that determines what your overhead is. And your overhead is what gives you your profitability.
Right.
So can you break that down?
Honestly, I think it's the opposite. When you're in a rural setting, the practice I bought was still doing pin retained amalgams, 4 or 5 surface amalgams, patching everything. There's
so no like lasers, no like
no
CBCT,
lasers,
no technology.
I have a CBCT in my office. The oral surgeon had one. They closed that office down, and so I have the CBCT in the office, or in the town. There's no laser dentistry other than my little diode laser. Nobody else has a laser. The orthodontist has an intraoral scanner. Nobody else has an intraoral scanner. Nobody else has an in-office mill for making crowns. So if you're, and I don't think this is necessarily just rural, maybe more so because there's not as many options to go to. But
Right.
Dentistry, it's very easy to get in your own little office, your own little island, do the minimal amount of required continuing education every year, not have anybody overlook your work. So there's nothing really pushing you to learn more, do better, other than yourself or your professional colleagues. And if you don't have that, where it's just you and you're fine with status quo doing copper bands and large amalgam buildups that you learned 40 years ago in dental school, it's worked for 40 years. Why should I change it? So,
with that being said, do you think that technology makes people better, makes dentists better? Does that make sense? Do you think
yes.
that if you were to have one office that had all these like bells and whistles and all this technology and another one that really didn't, do you think that a patient would say, well, because this person has all this technology, they must be a better dentist? Or do you think that it really doesn't even matter? It's just a matter of, like you said, taking advanced classes and so forth? Does that make sense? Because patients look at new stuff and go, it's shiny, it's new, it must be
Right.
better.
I think there is a certain percentage of patients that like going to an office that is up to date, has the latest technology, that can be efficient if they can use that technology appropriately. I don't necessarily think it makes the dentist better. You guys have placed way more implants than I ever will. But with bringing technology in, doing a surgical guide, cone beam guided or surgical guided surgery, a monkey can place an implant that way. But if you run into complications where you have to lay the flap, where the bone isn't what you thought it would be, if you don't have the skill set, technology can also get you into where you're in over your head if things don't go as planned. So having a grasp of that technology is definitely crucial.
Do you think the patients know the difference? Because the way I like to think about it is, if I was your layperson, and let's say I'm going in for prostate surgery or something internal that's a bit more grave than our oral cavity, right? If someone was to say, yes, we use the latest imaging technology and orthoscopic techniques to be less invasive and blah, 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 blah. In my head, I see that not only as a quality, but as a way of receiving treatment that's less rudimentary and potentially less invasive than before. Is it reasonable that your average patient would have that same view at dentistry and say, oh, okay, if they got more technology, they have more information, they can be more precise, they can be more, however you want to put it, because we may know the difference, right? But we're in the industry. How do you think we need to explain that to the layperson, that it's not always all about the bells and whistles?
Right. I think it comes down to, one, patient comfort, number of appointments, length of appointments, and cost would probably be the three biggest things that I think about when it comes to patients and how they perceive technology. So for instance, when I bought the practice, I was doing traditional impressions for a crown. Do an impression, send it to the lab. You're going to wear a temporary crown that I'm going to make chairside. You're going to wear that for 2.5 weeks until the crown comes back. Then you're going to come back in for a 10, 15, 20-minute appointment to get the crown put into place. Sometimes we're going to have to numb you back up for that appointment if it's uncomfortable for you. Patients don't like the goop in their mouth. So once you introduce an intraoral scanner, they can see it on the screen. Oh, you mean I don't have to get that goo in my mouth? Great. Cuts down on time, cuts down on expenses, makes the patient more comfortable, number one, for the patient. Add in an in-office mill. Hey, remember how you used to wear a temporary crown? We don't have to do that anymore. I can mill you out a crown in 45 minutes. Zirconia crown that's going to fit the same exact way that comes from the lab. Just hang out, go run some errands, come back. We'll get this cemented into place. You don't have to worry about coming back another day. You don't have to worry about temporary crowns. You don't have to worry about getting numbed up again, because you're still tooth is still going to be asleep by the time we cement this in. Wow, that's really cool. I can see it on the screen. That's a lot different from how the rest of my crowns were doing. So that takes care of comfort. That takes care of patient time in the chair. I think patients struggle with the cost aspect. They like the new technology, but sometimes they might equate that to, oh, it's going to cost me more money. So it depends on that type of patient. If they want to pay the cheapest price possible, there's always somebody cheaper to find to do it, if time isn't a concern for you. But there are other patients that say, I appreciate saving me time. Time is money, so I'm okay paying a little bit higher fee for that access to technology.
Well, this is a good segue, because if you're thinking about the cost of all that stuff that, for you to bring this technology into your office, right?
Mm-hmm. Yep.
How are you as a private owner able to compete with, say, a large corporation who has capital investment backing it, who has the ability to buy stuff cheap because they're buying volume? Yep. And they open, let's say, Pacific Dental Services or Heartland, they open a practice half a block away from you. Right. And they're able to throw everything in that practice, from your CBCT to your wave endodontics, your trio scanner. Where do you see the industry going for a solo practitioner like yourself in the context of what we're seeing with the corporatization of dentistry that can provide all this stuff very cheap, and sometimes, kind of the Walmart method where they'll just undercut their prices until you go out of business before they raise their prices to, conventional and normal costs.
Real quick, Kyle, do you guys even have a DSO in your town?
Yes.
Okay, go ahead and speak on that then.
So it comes down to pieces of the pie again. If we look at patients as piece of the pie, or patients as a whole, there's a certain type of patients that they just want to do what is covered by insurance. They don't care who they see, who's treating them. I think that is a great patient that can go to a DSO model, because they struggle with getting dentists to come to rural areas because of quality of life. Whether it's the dentist or the spouse doesn't want to be in a small town away from, the glitz and glamour of a city. What I've seen is rural areas, the dentist will usually stay on the length of their contract, a year or so, and then they move on till another dentist comes in. So to patients where the continuity of care with the same provider doesn't matter, that model is a great access to care for them. For patients who want that relationship, who need that trust with their provider, need somebody that's going to be there for the next 10, 15, 20 years. If there's going to be a problem arise, that it's not a different treatment plan with a different provider every time they come in, then that private practice model is always going to, in my opinion, have a place, because it's in rural areas, and to the same extent, I think cities also, with the generation of dentists coming out, there's a lot of mobility moving around the country. So once you own your practice, you're going to be there traditionally for a while, unless you're back to perio residency. But
real quick, Kyle,
that was out for you, Roy.
no. With that being said, Riddy, you said something that was kind of interesting. You said that, even with corporations, the doctors will come in and leave after like a year contract, right? But that would also speak to you being able to hire people, right? How hard is it for you as a practice owner who wants to maybe cut back on hours or see more patients to bring in an associate if no one wants to live in these rural areas? Or am I misspoken when I say that no one wants to live in the rural areas? And is it easy for you to find an associate?
Definitely a struggle. As I said, people don't want to come here. DSOs have a lot bigger marketing budget, a greater net that they can put out there, money to invest in attracting people with sign-on bonuses, guaranteed salaries that a private office typically doesn't have the resources for. A DSO also has a network of mentor dentists or continuing education that they keep in-house, that they can entice residents to, or not residents, associates to entice them to come work for them. General dentists or private practices don't have that, or are reluctant to offer that, to invest in somebody that may just leave in a year. So that's definitely a challenge. Same thing when it comes to selling a practice. There are lots of rural dentists that are looking to retire. There is nobody after years of searching, and they end up closing their doors. And that, a friend of mine who was in the late stages of his career, dealt with cancer and passed away. The practice consultant that works with my office and his worked for months and months trying to find somebody. It was a highly profitable fee-for-service practice in northwestern Pennsylvania, and several people came to look at it. They did worked a couple of days in the practice, and what could ultimately become a cash cow of a business as a fee-for-service. In his town, there was only one or two other dentists, so there was literally no competition. But that lifestyle wasn't attractive to all the potential buyers. They did end up selling to another older dentist who had some challenges earlier in his career. But to be a young person coming into a practice like that, it's, you're miles ahead buying something like that versus working for a DSO. Part of the issue is it's hard to find those practices also, because they don't know where to look for them.
Gotcha. I got a question for you, buddy. I'm going to put you in a hot seat.
Okay.
Hope you appreciate it. So I'm going to ask you a couple real succinct yes, no type questions. And then that's leading into my bigger philosophical question.
Okay.
Do you agree that to whatever extent it's the responsibility of the, say, dental education industry to produce providers that will go to high need areas or underserved areas?
Yes.
Okay. Do you agree, as your story exemplifies, that being from somewhere that's rural, underserved, makes it much more likely that you will go back to these areas?
Yes.
Okay. So when I was looking down earlier, prepping for this, I had looked up this study by Amelia Goodfellow that talked about what are some of the things that are precursors to people going back to underserved areas, whether these areas are rural, more farm communities, agricultural communities, whether these are ethnic communities, right? And the gist of every population, as you break it down, is you're more likely to go back to where you come from.
Right.
So I want to know what your view is when it comes to potentially creating either scholarships, holding positions for people, whether it's due to their geographic background, their ethnic background, their financial background, holding positions in these schools to create providers who in some cases are 10, 20 times, 30 times more likely to go back and practice in these underserved areas.
So I was a benefit of a scholarship that was set up by a dentist in Bedford that ended up working at University of Pittsburgh, where I went to dental school. So I received his scholarship. It helped. As far as scholarships go, a couple $1,000s a year toward the astronomical cost of dental school is really a drop in the bucket. Mm-hmm. I put more of the blame on dental schools, and I'll speak specifically for Pennsylvania because we have 3 dental schools: Pitt, Penn, and Temple. And there's also Lake Erie College of Medicine also does some dental rotations. So we'll say 3.5. For the 3 main dental schools, a lot of states that only have 1 dental school show preference to in-state residents. Pennsylvania, because they're dental schools, I think we had almost 50% of our class that was from Pennsylvania. We had a lot of international students. We had a lot of out-of-state students. They pay our higher tuition, and from what I've heard, the school was also getting higher, not kickbacks, but a higher reimbursement from the government to have those types of students in the school. So if you have dental schools that are in the state that are taking a majority of out-of-state students, then those students aren't going to stay in the state. They're going to leave, and to try to attract a student or a dentist from another state to your rural area, to your state, becomes more challenging. Mm-hmm. So I think the issue is it's generally cheaper to go to an in-state school that you're a resident of. So if the schools would take more in-state students, and in my class, I felt dental school was looking at grades only. Mm-hmm. And grades are important. Your intelligence, your ability to get through dental school, get through the academics of it is important. But dentistry is working with people. And a lot of those people, when you're in the class, don't have a personality, can't have a conversation with people, to the effect that dental school had to put in empathy classes to teach people how to be empathetic towards patients, which I think is absolutely ridiculous.
Wow.
So part of that interview process needs to be, well, your grades aren't the best. They're not the worst. I think you can get through dental school if you put the effort in, but you seem like you're a really good person. You seem like you're caring. You take care of people. You can have a conversation with people. You can break it down to basic language. If they looked at that aspect also and attracted that kind of student, I think that would benefit the in-state access to care issue. So to circle back, I think dental schools take a lot of responsibility in the access to care issue. And I think it ultimately comes down to money with how much they're getting in-state versus out-of-state.
Yeah.
Yeah. So the last thing I want to ask, and this would be my last question, would be, so we've kind of almost talked everybody out of going to rurals, it sounds like, right? If you think about it, I'm not sure if we said anything positive, but I'm going to give you an opportunity now to basically let us know, right? Because again, in dental school and so forth, we're always taught, if you want to make money, if you want to have that work-life balance and everything, because I believe you work 4 days a week.
We're about 3.5 right now.
3.5, right? That's amazing. So if you want to have that work-life balance, you should definitely go to the rural areas. We have the challenges, but please let us know what are some like the benefits, so that any dental student that's listening might say, you know what? Why do I need to live in Pittsburgh when I could live 2 hours away and then take my Ferrari into Pittsburgh to have dinner? You know what I mean? So maybe let's talk about that, man.
So if you got into dental school and you made it out of dental school, there's some degree of motivation, self-motivation that you have. While private practice ownership isn't for everybody, I think if you want to get ahead financially, short-term and long-term, ownership is really the best way to do it. Control your own destiny, be able to invest in the things that you're interested in, invest in the technology, invest in the continuing education. Private practice ownership allows you to do that. And specifically rural dentistry allows that option because you can practice however you want to. Sky's the limit as far as the procedures that you want to offer to patients. And like Walter said, work-life balance, being an owner, my commute to work is 5 minutes and I see 2 or 3 other cars on the ride to work. I can go home for lunch if I want to. I live in a place where I don't see my neighbors and I can go out in the hot tub if I want and not have to worry about somebody peeking over a fence or looking down at me from a 20-story building. It's a lot quieter, which again goes into lifestyle, what you want out of life, but you have a sense of community. Your patients know you. So if you're a good person and you treat people fairly, the money is just a secondary benefit to it. So being able to treat people how you want, not worrying about competition. It's not competition, it's community. It's taking care of the people that you see on a day-to-day basis. And practicing and setting up your life really how you want it to be and being in control of your own life. Sky's the limit. If you want to work 7 days a week and crank out as much dentistry as possible and drive that Ferrari, that is available to you. But cost of living is significantly lower than being in a city, so you might not have to work quite as hard to achieve what you would in a city. Granted, there aren't as many shows or restaurants, but a short hour, 2-hour drive, it's a nice weekend getaway if you wanted to get to a city somewhere. So if you're looking to get into rural dentistry, best way is reach out to dental societies. The Academy of General Dentistry, each state has their own chapter. There is a great resource that they can send out emails to all their members. The American Dental Association has the same thing. So Pennsylvania Dental Association, Pennsylvania Academy of General Dentistry, or research an area, find an area that you like and just contact the dentist in the area. Hey, this is me. Here's a postcard, a little history of what I'm doing. Just looking to see if you're interested in adding an associate or maybe talk about selling your practice. If you wanted to sit down, have a meeting, see what's available. So finding the area you want to live in and then finding if there's an opportunity in that area, because a lot of dentists that are getting close to retirement might just have in the back of their mind, I've made my money. If I sell the practice, that's the cherry on top. I'm planning on just closing my doors. So getting a postcard in the mail or a phone call or a letter saying, hey, would you be open to this opportunity? That is probably a pretty easy in if you want to go to that area.
Yeah, that's what's up, man.
I don't know what to say.
I appreciate the answer to the question that I asked. I feel like a lot of people especially dentists, feel like everything should be a very specific, kind of narrow viewed meritocracy as they've defined it, right? But I think your insight that it's not just about having the 4.0 and that, hell, with the 3.2, you probably still do just fine in dental school. But what else makes you a good clinician, right? So why don't you tell us, and my last question will be like, what are the top 3 character traits that you think would make someone successful in a rural setting, given the individual cultures of a place like Bedford?
One would be, I think a job everybody should have is waiting tables. It teaches you to talk to people. You're earning your money through tips. It's being able to read people. So having the ability to talk to people on their level, and coming from dental school, we're taught this whole new dental language, all these technical aspects of the mouth and the anatomy. Second thing, being able to dumb that down and say, this is a cavity, this is what's going on, and explaining it in a short 10, 15-second clip that the patient's like, okay, I understand what that is, not trying to sound as educated as possible and being above that patient. So being able to talk to them, in a language that they understand and respond to. Third is just being an honest person. We all make mistakes, owning up to your mistake. Hey, this didn't turn out right. I made a mistake here. I'm sorry. I'm going to fix this. It's on me. So I have an unwritten warranty policy in my office. If I do a crown and that crown breaks the first year, I'm going to replace that crown at no charge to you. If it's second year, I'm going to cover 80% of it. Third year, I'm going to cover 60%. After 5 years that crown breaks, I figure I did my job and you did something. So having that conversation with patients that I'm not going anywhere. Money isn't the most important thing to me. My reputation and how I take care of you is important. So being a good person and backing up the work that you do and making people know that I don't have all the answers, but I'm willing to take responsibility for something that I may have gotten wrong and help you get to the place where we want to be.
That's awesome. And honestly, I think we can all agree that that's the qualities you need to have, period, as a dentist.
Right.
Live,
and as a person, individual. Yeah, any person, not just dentistry. So
right. Yeah. So, well, thank you, sir. Really appreciate you. We know that's late where you are, so we don't want to hold you up. And I know you like to go to bed early, like I do. So.
Yeah. And shout out to Leroy. We're still trying to get you to Pennsylvania to give us some of that knowledge you got.
I'm on my way, man. We're working it out.
That's awesome.
I appreciate you.
Well, man, hey, enjoy your night, man. We'll talk soon.
All right. Have a good night, guys.
Take care, man.
Thank you for listening to this episode of Truth Be Told. The opinions on this episode are just that, our opinions. Please consult your dental professional before taking any action with your dental health. If you have any questions about anything you heard on this episode, please contact us at Real Dentist with an S. That's REAL Dentist with an S at gmail.com. We would be very happy to return any message that we receive because we love the communication that we have with our listeners.